Welcome to Friday Friends, RI Elder Info's weekly look at the organizations and individuals providing resources for Rhode Island seniors, caregivers, and professionals.
Good morning, everyone. Happy Friday. As you know, if it's Friday and it's 9 o'clock, I am here doing Friday Friends right here on Facebook and YouTube and LinkedIn and podcasting all at the same time. Because here at RI Elder Info, it's really important that we get you the information that you need. And today's conversation is really going to be pretty different because I know here in Rhode Island, we don't have a lot of specific resources on the topic that we're discussing today. So it's super important that you hit the like button and the follow and the share and all of those things, because there are folks here that are experiencing Lewy body dementia. And this is a wonderful opportunity for the individuals experiencing LBD and their caregivers and the professionals who serve them to have their questions answered. My guests are always happy to take questions. So today is super important that you share this out to get the word out. Because we don't have a lot of resources here in Rhode Island. I'm bringing these folks in from out of state, and I'm really blessed. So as you know, RI Elder Info is a nonprofit, and we can't do what we do without the support of our sponsors. So big shout out to Oak Street Health and United Healthcare and Tamarisk Assisted Living. We can't make this magic happen for you without 321 Media. And if you visited rielderinfo.com, you have seen the wonderful work of England Studio. We are also really grateful for the Ocean State Center for Independent Living for being our sponsor of Friday Friends this month. Here's a word from OSIL.
Do you have a disability and want to be more independent in your home and community? Do you experience barriers that keep you from living life on your own terms? Ocean State Center for Independent Living in Warwick is there to help. Call 738-1013 or visit their website at oscil.org to learn how they can assist you. Ocean State Center for Independent Living is Rhode Island's go-to organization for disability services, resources, and information. Visit their website at oscil.org and begin living your life on your terms.
So today we're talking to Brandi Hackett from the Lewy Body Dementia Association. She's coming to us all the way from Georgia. Hi, Brandi.
Hi, everyone. Thank you so much for having me, Deb. I'm really honored to be here and representing LBDA.
Yeah, we're super excited to have you. I know that there's a lot of folks watching because we just don't have a lot of resources on Lewy body dementia here in Rhode Island. And so I wanted to have you, come on and explain, what is Lewy body dementia? How is that big? How is it different from like the big A Alzheimer's that everybody knows? So could you just share, like, what is LBDA?
So LBDA, I'll start briefly with that. We're an organization based out of Georgia. It stands for the Lewy Body Dementia Association. So we're based out of Georgia. We're a small organization, but we do serve nationwide. I'm part of our support team here at the association, and part of my role is our helpline, or our Lewy line, as well as supporting our support volunteers nationwide. About LBD, or Lewy body dementia, this is a disease that's primarily caused by a buildup of a certain protein in the brain. And it's a necessary protein that our brain needs, and it's called alpha-synuclein. And they're not real sure why yet. There's a lot of research trying to figure out, the cause of why they are these buildups in the brain. But what happens is alpha-synuclein sort of builds up, and it creates this thing called a Lewy body. And so when we're referring to Lewy body dementia, we're referring to the changes that are happening to the person's cognition, movement, behaviors, etc., that are really caused from this protein deposit in the brain called a Lewy body.
Okay. And wanted to say good morning to Patrick and Kate out there. And for Lewy body, is it associated with any other diseases, or is it something that you can prevent? Is it um, something you can catch? How does this happen?
Again, they're not exactly sure yet. A
Okay.
lot of research, they think it's probably a combination of biology, aging, environmental exposures, potentially genetics. So there's again many potential root causes and some correlations that they're looking into. But in terms of being something you can catch or it's contagious, it is not. We do have some instances that are brought to our attention either through our volunteers or through the calls that come in where it seems that there may be some kind of genetic link because it's showing up in multiple people within one family. But it's just, again, they're really just trying to determine the root cause. It is a very different dementia than Alzheimer's. Alzheimer's, when we think about the changes, we're really thinking about the changes in cognition that are related to memory primarily. And yes, there can be multiple other physical changes over time, et cetera. But um, for us, what we tend to see is, I love Dr. Armstrong out of Florida. She simply says cognition is memory and thinking. And so to have cognitive changes, it's really you're looking at what someone's prior baseline was, and you're looking at their changes to their thinking and memory. For our dementia, we do see, especially in the beginning, a lot more changes to someone's thinking, their ability to multitask, some visuospatial, which is sort of how we are able to determine where we are sort of in space. So, distance from items, for example, wayfinding in a house or in a space, um, judgment, what they call executive functioning, which is just sort of how we get through the day. So, it can present from the cognitive angle very, very differently than what people know as Alzheimer's dementia or the changes involved. Where it can get difficult is sometimes it can be a mixed dementia. So it may be a dementia that has multiple root causes as opposed to just the brain changes that we've talked about because of the Lewy bodies in the brain.
So, how does Lewy body present? What does it look like for the individual who has Lewy body? Like, do they know that they have Lewy body dementia? Are they aware of it? And what does it look like? What are some of the behaviors? And we know that behaviors is just a way that we use our body to communicate. Um, so, how does that appear for the individual and for those folks around them?
Are they aware? We'll start there. Very much, very frequently, almost always, we hear yes. So there can be moments and situations where the awareness is reduced, that they're not as aware. But I can tell you, it's a very different presentation. With ours, we see a lot of what's called fluctuations. So it's this, as opposed to with Alzheimer's, it seems to steadily decline over time. Ours can feel, as some describe, more like a roller coaster even throughout the day. So there can be moments where a person feels much more able and really is much more able, and other moments when they're really not. For us, for me especially, I like to sort of break things down as simply as possible so that I can understand it and then try to help others understand it. I think about these symptoms in buckets. So for
Okay.
me, we do have the bucket of cognition, which we've talked the most about this morning. So the changes in memory and thinking. There's also a bucket of sleep where there can be insomnia, restless leg. We have many, many which present even sometimes decades before an official diagnosis with a condition called REM sleep behavior disorder, where the person is physically acting out their dreams as opposed to being still as we normally are during our dreams.
So that's
Uh,
like when somebody is having like they're thrashing around a lot in response to how they're dreaming, like they're like swinging and things like that in their dream state.
yeah, so REM
Wow.
stands for rapid eye movement. And it's really when we dream, our bodies are typically very still. And so they call it that because the only part that you can typically see moving is the eye, sort of twitching, um, for some reason. And again, a lot of the causation is still under study, but that sort of tricks or flips where you just don't have the maintainability for that stillness that you would before. And what happens is sometimes that can cause injury to the person. Because if you can imagine, if you're thrashing around responding to a dream, you may yell out, you may hit a bed partner, you may hit a dresser next door. We've had people fall out of bed. So the sleep bucket can be problematic not only for the person that's experiencing it, but also for the care partner who's also experiencing it alongside them. Um, exactly. And then there's a bucket of what I call mood or mood changes. So we're looking at really chemical depression, anxiety, restlessness, apathy, really just very low levels of things that may have once brought them joy, may have once brought them purpose, just being stuck. A lot of people talk about really a lack of motivation, like I just can't, I don't have it in me. And then, of course, again, behavioral, as you mentioned, for us, one of the key unique features is going to be the presence of both hallucinations and or delusions. Sometimes there can be something called an illusion or a misperception as well, which is
What?
basically there's something physically there, you just misinterpret what it is. So your brain misinterprets. So the coat rack is a figure, for example, or it may be you have a weird feeling of someone in the room with you, but you're not seeing anything physically.
I have a good
Hallucination.
question.
Sorry. Yeah. Go.
Good question. What is the difference between hallucination and delusion as it relates to Lewy body?
Yeah, they can dance together pretty well, but so a hallucination is really a perception of something outside of self through our senses that isn't there.
Okay.
So typically we see visual hallucinations. So that is something that you are seeing
Okay.
in your presence that others aren't. But I'll be honest, we hear about other sensory hallucinations as well. A lot of people will hear music or voices. We had, people that smell certain things, taste, touch. It can really affect multiple senses. A delusion is different because it's a fixed, false belief. So some of the most common delusions that we hear about would be um, accusations of infidelity. There is a true stuck belief that the partner is cheating. Um, we have one called ekbom, which is the presence of parasites or bugs. There is one called capgrass or capgras that there's multiple versions of the same person. So, like for example, you're not the real Deb. Where's real Deb?
Oh, okay.
So often it can be, trying to think of some of the more common ones. Phantom boarder, people in the home with them. So that, there is, 5 people sitting in our dining room. There's 3 people in my bed. There's a lady living downstairs in the basement. Um, the issue is, it is so real to them. So real. And when our brain thinks something is real, we react completely, physically, emotionally to what our brain is telling us is true. And that's what makes this a lot harder at times to support, is because, so the example I use sometime with, especially with caregivers trying to understand, and I say, okay, Deb, let's imagine right now you're getting chased by a bear. Your brain is telling you you're getting chased by a bear. Okay. Yeah, you're going to have all kinds of responses, which may include screaming, yelling, cussing, fighting, urinating on yourself, hiding, running, fear, and all these additional feelings that you're feeling. And so, what a lot of people do is when a person is having a delusion, hallucinations, what we want to do, what makes the most sense is to say, Deb, there's no bear. You're fine, there's no bear. And I think sometimes that's what's taught, especially in the trainings involving more Alzheimer's dementia, is that reality reorientation, redirection. But again, if I were to say to you, Deb, there's no bear, and you seriously think there is a bear. And if I follow that with, it's time for your breakfast, you would think I'm nuts, because you would think, like, why in the world aren't you listening to me? I'm scared. I have these needs.
Mhm.
And so delusions can be like that to those that are experiencing. They can be the bear, the threat that is really stuck in their brain. And unfortunately, when our brain thinks something is true, we pick things out of an environment that sort of support that, if that
Yep.
makes sense. So,
Yep.
for example, if I think that my husband is cheating and all of a sudden I look over there and he's on his phone, my brain may tell me he's talking to his girlfriend as opposed to he's playing that video game he's addicted to on his phone. Okay, so
Yep.
the issue is sometimes the things that are in their environment back up what their brain is telling them is true. And so it can dig in deeper and it can be harder to support. So
So I have a
often the
question.
techniques are, yeah, go ahead.
So some of the real person-centered training and dementia practices regarding Alzheimer's is not so much to reorient somebody where they are versus accept where they are. So if someone is, say, looking for their mom, you don't want to tell them, you're 90 and your mom has, long been gone, but you want to say, it's okay. Maybe she went to the store, but we're good, and redirect. But it sounds like when somebody has Lewy body and they really believe that there is something about to harm them, that, like you were saying, like offering them breakfast, if I'm thinking that there's a bear coming at me, that's going to sound bizarre. So when you're seeing your loved one locked in this battle that isn't real, what can you do? Because you see them truly terrified,
Mhm.
truly agitated, and it's heartbreaking. And what can you do as a caregiver? Because you don't, unlike Alzheimer's dementia, you don't want to reinforce and say, why, yes, there's a bear coming. Of course there's a bear coming, and we're going to feed the bear berries. Like, you don't want to do that with Lewy body. So how can you work to really comfort the one who's experiencing this?
Yeah, it's not easy. And there is no what I would call script. There's no thing that always works. And that's the hardest part, is even if you can find something that works, sometimes it stops working. Sometimes it shifts, just like supporting anyone and anything else. It can,
Mhm.
not be as effective in other times. But, you know, typically, if you look at some of the research that Mayo has done and some of the things that are put out and specific to supporting someone with Lewy, what it tends to lean into is, and I think my background's in psychology and social work, and so I think about cognitive behavioral therapy. So if you think about it as a triangle and you have cognitions or thoughts, emotions, and behaviors,
Mhm.
I like to imagine that you take a stick pin and shove it as hard as you can in the thoughts. And let's just pretend for a minute you're not going to take away the bear. Okay, so then what can we do? What can we shift to show support and comfort? What I try to do is take a step back and take a deep breath as a care partner, because you need a little bit of space and grace to figure it out. So I think just sinking back and saying, okay, what could be helpful is important. Start looking at the emotional reaction and the behavioral reaction, and what can you do to support those? Because again, if this is the triangle, that part is stuck for a minute. So ideally, you want to, what I call, blip the system enough to try to provide really the core of what we need as humans. And so for me, I always say that is to be heard, that is to be understood, that is to be loved and safe. And so if we can say, if that were what my brain was telling me was true, what would I need? So if you go back to loved, understood, heard, and safe, what would you need? So it doesn't mean it's like, oh, well, that's the magic answer, let me do it. But
Yeah.
sometimes what that does, so if we take the bear situation, I'm not going to say let's feed the bear berries, because the bear's scaring you. But what I would say is, Deb, shh, come here. Come here. I know you're exhausted and you're tired and you're scared. Sit right here. Let me make sure the bear goes out the front door. And I'm going to make sure it's double locked so it can't come back in. I know you're thirsty. Let me get you something to drink. Okay. It's not always that simple, but the idea is sometimes you do have to lean in. You do have to say, I've had families do fake eviction notices. I've had one family even call our helpline using it as calling the cops. So they left a whole message for the cops on our helpline. Not necessarily ideal, but they wanted to show proof that they were calling somebody and they chose to call us, which I thought was sort of cute. But it's what does the person need? And I think we forget the core of the person is still there. Their needs are very much still there. And they're responding really genuinely appropriately sometimes to what their brain is telling them is true. That's the hardest part. So again, you could do a million things if you were getting chased by a bear, and I wouldn't be like, Deb is showing some inappropriate behaviors, because if you were right, I mean, it would be genuine. What
Right.
you're doing is truly what you think is true. So often technique. So when there's behavioral presentation, just like any dementia, but especially with ours, is there any at all physical cause? So sometimes physical distress, pain, constipation, etc., ingrown toenails. We've had just a host of physical causes that can cause enough distress to sort of set the mind going. Then we want to look at environmental factors. And so there could be, like I had one lady who was talking about she couldn't sleep because a man was standing over her bed and lecturing her. And the daughter had actually put out a coat rack at the head of her bed that if you think about lying down in bed and looking up, a coat rack might seem like a person looking over you, sleeping. So, go into a room, turn off lights, check out shadows, look at mirrors, certain windows, certain photos, certain TV shows. What are things that could be adding to the content that they're experiencing? Look at medication issues, even if it's a med they've been on a while. Is it something that's causing some kind of side effect, or is it a new medication that was just started that they need to talk to the doctor about? The techniques that we've talked about, you really want to lean heavy into techniques. And sometimes you're doing all of this in tandem. It isn't just step one, step two, step three, but you're really looking at all of that. And then if there's still no relief, get with a medical professional about potential treatments that could be helpful, which can include things like medications. We do have to be careful with Lewy because sometimes the meds that are used for things like hallucinations and delusions, such as some of the antipsychotics, can be pretty dangerous for those with Lewy. So we do want to make sure that the doctor is both providing and receiving good guidance on that. And we have some wonderful publications that are available on our website, and we'll make sure that you have. And so if anyone were to reach in, you can share those as well. But we have wonderful publications called Behavioral Treatment of Behavioral Presentation in Lewy Body Dementia. And it really talks through some of the medications because sometimes a family can do everything right. They can do everything supportive, and it's just distress for the person that's experiencing it. And again, we see that the fluctuations exist with this too. So this doesn't mean that this is a continual space that they're in, but it can surface and can be problematic.
So this just sounds from the caregiver perspective exhausting and frustrating and really sad. Are there support groups that the Lewy Body Dementia Association offers, or can you help? We don't have one here in Rhode Island. Can the Lewy Body Dementia Association help if people want to set up a support group here in Rhode Island? Is that something, I know that you're located in Georgia, but is that something that you can help if there are viewers who are interested in setting up a support group? Can you do that here?
Mm-hmm. So support is available. So let me talk about a couple things that we already have in place, and we'll talk about a little bit about how to create support. So in place, we have from our support team a couple different levels of support. So we have something called Lewy Buddies, and we have right at 30 nationwide. These are our highest level of support volunteers. They provide telephonic support specifically to those that are in caregivers or care partners. And we also have now 7 individuals that are diagnosed with Lewy body dementia that are also telephone support mentors and part of our support network, which has been an amazing addition since last summer.
So somebody who has Lewy body dementia, you said a lot of times that they are aware. You have support services from other people who have the diagnosis of Lewy body dementia?
Yeah, yeah,
So they
and
can
that's how
talk like one-on-one and kind of have that conversation of like,
all
this
day.
is what I'm experiencing, and to have someone say, yeah, I experienced that too.
And think about how powerful that is when you're having such
Very.
changes. Yes, very much so. There's really a lot of misconceptions out there about dementia as a whole,
Mhm.
about abilities as a whole. I think a lot of people think as soon as that label is there that so much is they're not able to do. With our dementia, again, because it changes so differently than some of the other, 80 plus causes of dementia, but specifically different from Alzheimer's, they are keenly aware, very able. We have a support group. Pamela Corsentino, my boss here in support, she manages a weekly support group only for those that are diagnosed.
Oh, wow.
She's had people involved in that group for years that are still incredibly active participants, supporting others, etc. Um, some of the feedback that I get from individuals, and some that have talked to our volunteers, but others who have had the blessing in meeting others that are diagnosed through other channels, they talk about how powerful that is. Truly powerful to be handed, well, first to be seeing these changes. This is pre diagnosis, to be feeling and seeing these changes. And we have to think our dementia can affect people much younger. So we're typically 50 and older, typically, but it can affect people in their late 30s, 40s, etc. And so often these individuals are still working. They may still have young children. They
Wow.
may still have teenagers in the home. They may be still pending retirement with their job. So, they're feeling these changes. Things at work are taking them longer than it ever did, kind of thing. Um, and then you get a diagnosis, and depending on who they're talking to, it may be, unfortunately, there's a term that can be used called diagnose and adios, which we hate, but it's seriously like, here's a label. Thanks for coming. We'll see you in 6 months. And it's
Oh,
just,
jeez.
families are like, well, I even had a family call in and said, the doctor said, here's a brochure, call them, they'll help you understand it. And so,
Wow.
and again, not all. Believe you me, many doctors, neurologists, etc., take the time. But we see all types where people come to this diagnosis, this label, this experience, and then all of a sudden they're like, my life is different now. Our relationship is different now. My future is different now. And the internet can be a bit of a black hole in terms
Phew.
of just
Yes.
information. And as you all know, links can follow links can follow links. And you can literally like look up and it's 8 hours later and you don't know anything that you've read. And that's what a lot of people do is they get stuck in the black hole of just trying to understand it.
Yeah.
Um,
That's why I
and
wanted you on today because, we work really hard to help people get to the real stuff and not a lot of nonsense that goes down that rabbit hole. And that's why it was so important when I reached out to you to have you come on so people can hear it like in live time, like what it really is. N-
yeah.
eh,
And,
Do
and I'm
doctors
no, sorry.
usually look for Lewy body or do they kind of default to the big A or um unfortunately during COVID we saw a lot of increase in antipsychotic medications with the delusions. I could see where it could have an appearance of um some kind of severe persistent mental illness. So are the doctors educated to look for Lewy body or should somebody really go to a neurologist who specializes in it? Like, how do you find a doctor for this? Because you don't want to just have this bomb lobbed at you and then like, oh, check out the web
Yeah.
kind of thing.
And don't let me forget, ask me next to go back into support because I want to make
Yes.
sure to cover the support options that are there. But
Yes.
but
Oh,
we'll
sorry.
we'll
I totally
well, no, you're
interrupted
good,
you.
you're good, you're good. No, you're fine. I just don't want to lose my train of thought any more than I typically do. So, okay, for this, our doctors trained. We as an organization, medical schools as organizations, yes, there is training.
Mhm.
The issue is going to be neurology, like any ology, is a deep sea of information. And so you have to think dementia as an umbrella is so complex. Then you have Alzheimer's, which is the most common, R's, vascular, some of the next most common. But you've got, like I said, 80 plus, depending on who you speak to, different causes or types of dementia. So there's a lot to know. So not only is there a lot to know, but then there's a lot to exclude. So if you have a person, let's imagine 60-year-old John shows up in front of his primary care doctor and says, I'm just struggling. I'm just having a harder time at work. Having these stomach pains. I don't know, some issues with constipation. My brain's foggy at times. I just can't pay attention. Sometimes I'm just not sleeping well. Okay. What I have described could be literally 100,000 different conditions.
Yes.
Like
Yes.
and that's the hard part about our diagnosis is that it's literally excluding. So is it depression? Is it schizophrenia? Is it an impacted bowel? Is it an issue with a medication? Is it an autoimmune disease? Is it issues with your thyroid? I mean, when I tell you there could literally be a million causes for what these can be feel very vague experiences happen. And again, if we're talking about these fluctuations, sometimes they aren't continual changes. So it's like, God, sometimes I get X. So in an ideal space, if you're having noticeable, again, different from your baseline, changes to your thinking and memory that is affecting your daily life or frequent life, seeing a neurologist is helpful. As a social worker, I'm a little keen to say start with your insurance, just because to me, getting recommendations is wonderful, but if they're not in network, that can be problematic. So start with your
Amen to
insurance
that.
about potential neurologist. And so typically in our space, there is a specialized neurologist called a movement disorder specialist, and there's a wonderful link on a website I can send you, Deb, that has a movement disorder specialist directory on it. And that was shared with
Oh.
me by one of our neurologists to help people find that. But often it's sort of using insurance, using recommendations in your area. Often your physician may have a good recommendation for a neurologist that has more experience in dementia. And then often in that process, they're looking at pulling apart what all causes could happen with this. So is there blood work? Are there scans? Are there, certain medications we're looking at, changes in diet, potential mental health conditions? Sometimes there can be specific exams or tests that people will take. Sometimes they're pretty lengthy to really dig in to try to find out what changes are really happening or what potential deficits are there in their ability to think and remember. And again, for us, because it can show up in all these buckets, autonomic, sleep, when the person is meeting with their doctor, it's important if they feel like this is even a possibility to bring up all of those other symptoms. Because again, sometimes when people are in front of their ologist, they only talk about that ologist's body part. So if I'm with my cardiologist, I'm going to talk about my heart.
Yep.
If I'm with my neurologist, I'm only going to talk about my brain. And so urologist, we won't get too into that, but you get the deal. Like, so seriously, you
Yeah.
tend to talk about the part that ologist is specializing in. The issue with our dementia is it is definitely changes in memory and thinking. but it is also changes in movement, changes in sleep, changes in autonomic. It's all of these other things. So as you're talking to these ologists, it's really helpful to help them because, again, they can only doctor us as well as we allow them, as
That's
much
true.
as we tell them. So getting our thoughts together and saying, these are the changes I'm noticing, and then sitting in front of that doctor and saying, here's the changes I'm noticing, that allows them to know more to then in turn be able to help you figure out why. So we have a lot of people that call with symptoms, and possibly they're from different causes, but it's helpful with this differential diagnosis to give them the ability to feel empowered to really bring to their doctor what they're concerned with. So sometimes my job isn't, and of course I can't or won't, it's not possible to diagnose over the phone with, whatever. But often what I find myself doing is saying, you should bring up this. Let me help you figure out how to organize the information. When is your appointment? Is someone going to be there with you? So for me, sometimes it's really helping them feel empowered to have those appointments and
Mhm.
informed. Sometimes I'll send information beforehand, like our symptom checklist, so that they can say, okay, I really think this is what's going on. Here's what I'm seeing with real bullet points. As a social worker, we document something called AEB, as evidenced by. So for me, it's different to say, I'm just having issues with my memory. It's very, very different to say, I can't do multi step tasks anymore. I find myself at the sink and I know I need to do X, just can't maintain attention. So giving more details of what those changes feel like and what those changes are and how they present for that person is really helpful because, again, it helps the doctor say, these are changes and this is how it's showing up. So whether it's the care partner that's giving reference to, for example, the movement that they're having during their sleep, or it's the person who's saying, these are things that are really shifting for me and I need help finding some answers. But it's important, really, to me, that a person remembers that healthcare is care for them, that the doctors work for them. And I'm not taking away the power of the doctor. I have incredible respect for physicians. But we have to bring enough to them to allow them to do their job. And then we have to bring sometimes information to them. So I have tons of people who give information to their primary care doctor. I really think this is what's going on, or these are my concerns that I'm having. And then that primary care doctor may go, whoa, this is a little out of my scope. Let me get you to a specialist. And so sometimes it's empowering the doctor to make shifts, but it takes really both sides. It's not just the doctor recognizing changes, it's really the person being able to bring enough information to the doctor to recognize those changes.
And I think that's really important too, to have that checklist, to have like kind of an idea ahead of time, because on average, I think doctors have about 7 minutes that they're kind of allotted to be with you. So when you're bringing in a collection of symptoms that could be a million different things, to have something more focused, to say, like, my bed partner is saying, like, I'm really thrashing around, and the multi-step, and then to list all of those things. I think that's really helpful when having the conversations with your doctor when you kind of feel like something is off. And I did want to remind you about the support group that I had
Yeah.
interrupted
Let's
my
do
own
that.
question on.
No, you're good. So my last thing on the topic we're doing is I tell families, think bullets, not dissertation. Because a lot of people will literally come in and be like, when I was born, this is what
Mhm.
happened. And so for me, it's, you do have to be aware that the time is limited, but what can I do to maximize the time that I have there? So, giving examples, I think it's also helpful. Have a med list ready, have a diagnosis list ready, have, other things. So if you've had a CT scan, for example, it's good that the doctor know that. If you have the results of that, it's good to have those on standby so that they have those. We also can't assume that this web talks. Ideally, it
Yeah.
would.
Yeah.
Ideally, it would. But sometimes it's, oh, that never got sent over, or, oh, yeah, I got it. I haven't been able to read it yet. So sometimes again, it's good to say we had a CT on April 1st and this were the results, and here's the printout from it. So having, again, the ability to give the doctor what they need to be able to help you is important. Going back to support. So we've talked about Lewy Buddies, which are telephone support volunteers. To connect to those, you connect to me, or our helpline, which is our Lewy line. And then in turn, we chat, try to figure out what's going on, what the greatest needs are, and then I can make those connections. I try to make connections. I laugh and I say sometimes I feel like Match.com for volunteers, but I'm looking at time zone, I'm looking at relationship, I'm looking at personality. I want to know often what the volunteer has experienced so that I can try to match up. So if it's a younger wife, for example, with teenagers still in the home, I have a volunteer that had that exact experience. And so sometimes being able to partner as much as possible, and it is never the same journey, it is never the same experience, but trying to make it make sense in terms of how those connections are happening. We have support groups nationwide, and we'll talk about sort of how, again, don't let me forget how to create one. But we have support groups nationwide. Many are still virtual. Some are in person now, but many are choosing to still be virtual, and many are actually open to out-of-state attendees because they are virtual. So sometimes I can make those connections. We have 4 Facebook pages that are closed. We have one for care partners only, one for those that are diagnosed only. And again, that page only has a built-in weekly support group through Zoom. We have one that's considered a dyad group, or a page specifically for those that are either pending diagnosis or diagnosed and their care partner. And then we just started about a year ago a bereavement page for those that have lost someone with Lewy that want somewhere to connect. So those are some of the layers of support that we can offer as an organization and help families to connect to. For creating support, we do have volunteer training that we offer every other month. So typically I just ask people to reach out to me either through our support email at support@lbda.org or through our Lewy line and just say, I have interest in becoming a volunteer. I have interest. We always want to be a little cautious on the volunteer and what I call their bandwidth. So if a person is in the midst of their own crisis, that is often not the best time to say, I'm also here for everyone else, because they really do need to focus on their own needs.
Yeah.
The same thing. I had a call just this week with a wonderful lady who wants to volunteer. Her loved one passed 2.5 weeks ago. For me, my response was, thank you. But typically, we want to give a little bit more time. Now, do we have 6.2 months after? No. Typically, my loose is about 6 months or so after. And often what I'll do is I'll say, do you mind if I touch base with you then? And we'll talk about if this continues to be an interest for you. For current caregivers, as opposed to former caregivers, we also want to take some of the same grace just to make sure that they understand the responsibility. They understand, what they're saying they would like to do. We do have, in all ideal space, a 2-year minimum to some of our volunteer positions, just because, as we all know, consistency is key when it comes to support. So we really want to make sure that people are at a space to know that they can be consistently available over time for these families. But basically, they would do a training with me. We would set that up. We had a volunteer agreement that we would have to discuss, and then I could help them sort of facilitate. Being a tiny organization, we have to be a little careful in like how much I can assist. So sometimes I can sort of, this is generally how it is. These are some tips. These are some things that can be helpful. But often the facilitators are really the powerhouses and bringing together some of the pieces and parts. So letting people know that the support group is available, getting the word out, connecting to local neurologists and saying, hey, just in case you have somebody. If it is what we call an official group with us, so if the person has been trained, et cetera, agreements, we can put it on our website, and that's available 24/7 to families. So there's many families that can get to the group without ever talking to me or to us here. So we try to make it where people can find support. We just do not have active groups in every state yet, but we do have what we consider coverage in every state because of the flexibility of the groups that will receive out-of-state participants.
That is awesome. So Melinda Burgard, she's watching. She had a question. How can I, as a music therapist, specifically help a person living with Lewy body?
Oh, that is a
Yeah.
very scope specific question. Not being a musical therapist myself, I would say try to find a colleague that does more work in neuro. Um, oh, that is tough. I have so many wonderful certified, board certified music therapist friends. I would literally, so if I got this question on the helpline, I would call one of them and connect the dots. I don't feel necessarily comfortable giving guidance on how to do clinical work for another discipline, but my advice would be digging as hard as you can to, um, anything within professional organizations that offer any kind of special certifications or training. For me, it's so personhood specific. I think Julia, who is an OT with us and our director of uh, education, is on the line too. I'm going to
Yeah.
hunt this to see if she has any further recommendations.
So Julia Wood's joining us in the audio stream. So Julia, can you answer that question regarding music therapy to help people living with Lewy body dementia?
Oh, absolutely. I'd be happy to.
Thank you.
So I'm part of a interdisciplinary faculty who teach training for the Parkinson's Foundation.
Mhm.
And we've had Conchetta Tamiano, who's a music therapist, work with us before, specifically on how you can address these issues with Parkinson's disease dementia and Lewy body dementia. And so a couple of ideas that come up, of course, like Brandi said, it's going to be very unique to the individual, but for orientation, for example, a lot of times they'll encourage people to have a song. Like, say, if shower time or going to exercise or transitions are difficult, then if you hear Law and Order, it's coming on if you're in the other room because you hear the theme song, right? So if they have a song that's their song associated to going to exercise class or therapy or getting in the shower, and having that kind of playlist that can help people orient. They start to link that music with that activity. So that can be a really great way. A couple that I worked with too, under kind of some guidance of a music therapist one time, she had a lot of trouble with Capgras syndrome, as Brandi mentioned, and they created a playlist that made me cry so hard because it was all, I choke up talking about it now. It was all songs from their life together, like songs they listened to on, we're singing together with the kids, driving in the car on vacation. The first song they danced to together. And we had this playlist. So then when she would start to think he was an imposter, they would have this, and they'd start talking about, remember when we danced to this song, remember that trip to, Yosemite or whatever it was. So there's a lot of ways that you can really use music, and music therapists are so wonderful in this arena to help with orientation, to help, people kind of, have a way to, it's like an anchor for them to come back to ease transitions. So yeah, please get in there with your knowledge, music therapist. So you guys can help a lot. Thank you.
Julia,
Yeah.
thank you for popping in.
Yeah,
Now I
thank
have like
you.
all goosebumps.
It was one of those, I had a student, you guys, and I was crying like a baby. I mean, I had to apologize to the student, but it was just one of the most beautiful moments I ever had, because seeing that insight into their life and seeing how she really lit up when they would talk about these things, it was just so touching. So yeah,
That's
you guys do
awesome.
great work.
Thank you
Yeah,
for
and
popping in.
I think it's funny
Absolutely.
because anytime I hear music, I hear some people sort of using it in the very unofficial way. Oh, I'm doing music therapy, but they're not music therapists, so they're trying to use music to provide support, et cetera. And I always laugh because I try to remind families it's music of their preference, not necessarily music of your preference. So there's a running joke in our house. I despise classical music. I'm really sorry if anyone's a performer here on this call. I don't like it. Something about it just distresses me. So the running joke is I've got to be like really aware and have it in all of my plans that this will make her agitated. So I can just imagine eventually they're like, let me play this calming music. And I'm like fighting. I could just imagine the coming out. So just trying to remember the music of preferences. I had a wonderful talk with one of our volunteers this week who was diagnosed. And he and I were on this exact topic. And we were cracking up because he said classical is his thing. And we were joking about that. But we were talking about how he said that when he's talked to others that are diagnosed and they're looking to use music in a supportive way just in their life to bring joy and purpose, that he's always said to key back into like their late teens, 20s, and 30s, that often that music will speak very like very much, and a lot more memories than you think will surface. And so sometimes it's easy now with music streaming. You put in one song and then you get like all these additional songs. And so he was saying that sometimes he has found that helpful in supporting others too.
That is really good. And you mentioned um, writing it down for the things that do and don't work for you. And I wanted to mention Carrie Lynn Edge made a note. She said her doctor told her to create a flow chart on one page to encompass her health concerns. Since they have such limited time to be with the patient, it helps the doctor to have a quick picture of what you're struggling with and what specialists you've been to, etc. So I'm thinking in that one pager, like including what does and does not work for you in the event that you're not able to communicate. So, if you have um, teenagers and they really want to annoy the daylights out of you, they will crank the classical music for you, Brandi.
It will be a problem. And my husband knows it, and so it's a problem. It's already a problem. And he's not a teenager, but we'll just leave it there. I think that to me, we talk a lot about what I consider a formal advance directive. So your powers of attorney, your healthcare directives, your wills, incredibly important. I do not shortchange the importance of those documents because, again, they are there. They are built to legally speak for you when you can't, to name people that you trust to speak on your behalf, to give clear and concise direction when you can't. However, I think there's pieces of this that we also forget. And so those preferences that we've talked about, I think that is part of advanced planning to have, what are comfort items? What are things that bring me joy and purpose? There is a wonderful, I believe it's a Jewish tradition, and I apologize if I'm wrong, but it's the tradition of ethical wills. So what do you want to leave in your traditions, in your beliefs, in your culture, in what's important to you and your priorities to those that come after you? It's really a beautiful concept. So I think having those conversations and having understanding, I think Julia just put up a tool as well that she's found helpful. I mean, I think that remembering the humanity in this is key.
Yep.
It can become very other. It can become very, well, I know about this and you need X. And sometimes we have to come back to the table and say, these are my priorities. These are things that are bothering me the most and really bringing back to the doctors, back to your family. And I think it's quite a dance. Again, no script. I find that often if you brought everyone together and say, what is your main goal? Often they share the exact same goal. It's just everyone has a different idea to get there. And so, for a person, I had beautiful conversation with a lady who was diagnosed, and she said, Brandi, I made one error on my medications, and now my daughter took that away, and she says I can't do that anymore. She said, but if she made one error, she'd still be doing, so I mean, and again, it's not to belittle potential risk, but it's those conversations. Sometimes I think our intent is for safety, our intent is for privacy, our intent is all these things, and sometimes we forget that we all need a little grace in this. We're all figuring this out together and trying to have that open communication of what that looks like for them.
Yeah. Yeah. I think that's really one of the most important things. So, Brandi, if people want to reach out to your organization, what's the best way if they need support to be able to reach you?
So the easiest way So a way you don't have to remember a number or anything like that is just to go to our website, which is www.lbda.org. At the very top of the page, you'll see it says Lewy line and a phone number, and it's a 1-800 number. That will come to us in support. That always goes to voicemail. So I think a lot of people think that it's just going to immediately, pop over to a person. You just leave us a voicemail and we will call back. We do try to call back same day. Sometimes that can vary depending on the volume of calls that we get. Another way to get into support is using our support email. And so that's just at support, SUPPORT, and then our website, lbda.org. And that goes right into the support team. I tend to be the one to respond to those. So you're welcome just to reach out and say, hey, we need this. And again, I just ask for the same space and grace that I try to give those that I serve. I do try to get back as quickly as I can from my end. Again, we are a very small organization. And so often we wear multiple hats, but we do try to support those that reach out to us as quickly as we can.
Excellent. Excellent. Brandi, I am so glad that you and Julia were able to join me today. I know that we went much longer than I had explained to you, but this was just such a great conversation. I feel like I've learned a lot. I'm sure my viewers have learned a lot. There have been some great questions. I really appreciate you guys taking the time to come on this morning.
Oh, we appreciate you giving us the space. It's a need that's really not discussed as much as it should be. And we just appreciate the time to bring the information. But please, anyone watching and yourself as well, Deb, and your team, if there's anything we can do, we would be happy to provide that care and service.
Absolutely. And we had your information there on the screen so viewers can reach out to you directly. As long as they understand it, you're a real human being. It might take you a minute or two to get back to folks.
Yeah. For sure.
Oh, thank you so much, Brandi. Thank you, Julia. I know you're still back there.
Thanks for having us.
Take care. Bye, guys.
So today we went really long, but you know what? There was so much great information. I really feel good about it. We don't have a lot of resources on Lewy body dementia specifically here in Rhode Island, so I really encourage you to reach out to Brandi and Julia. It's really important that individuals who have Lewy body and their loved ones get connected with the services and resources they need, and it will make life a little bit more comfortable on that journey. But I am really glad that you were able to join me, that you've stuck with me this far. I hope that you have hit the like button and the share and the follow so you can be notified next week when I'm live again. Also, you may or may not be aware that today is Rhode Island's Day of Giving, and RI Elder Info is a 501c3 nonprofit, and we use the donations that you provide to give back these types of educational information to our community. If you can support us, that's great. And if you maybe don't have the financial capacity and you just want to hit the share and the like button, that is really awesome as well. So I look forward to seeing you all next week. And in the meantime, be well and be kind.
If you liked this video, please follow us on social media and subscribe on YouTube. For more information, visit rielderinfo.com or call 401-585-0509. If you have any questions, email deb@rielderinfo.com.